Welcome to the PowerPoint for our second class together. This time we will discuss a concept that is very important for patient autonomy, capacity, and talk about end-of-life care. Our objectives today are to define capacity and its importance in autonomy and consent, talk about end-of-life care and understand the difference between euthanasia, assisted suicide, when a patient refuses treatment, and withdrawal of life support. We will define different types of advance directives, including healthcare proxy and living will. So, diving right in, what is capacity? Capacity is the ability to understand the nature and consequences of a decision, including the benefits and risks of, and alternatives to, any proposed healthcare, and to reach informed decisions. We say that patients must have capacity to be able to make their own decisions, to have autonomy, and to be able to consent. If someone does not have capacity, we talked about how their autonomy can be restricted during the first class. Like if someone is suicidal, they can be hospitalized against their will. It does not mean that the patient makes a decision that we think is the right decision, or that we agree with what they decide, but only that they understand the implications of their options and are able to choose between them. Capacity can be impaired by psychiatric illness, as we said, or medication or dementia, for example. Keep in mind, though, that simply having a diagnosis of an illness like depression does not mean that a patient lacks capacity. More must be assessed to know if the illness is impairing their ability to understand the nature and consequences of a decision. One additional point about language. We often hear people say that a patient is competent to make their own decisions, but competency is actually more a legal term, not medical, so while you may hear them used interchangeably, we'll try to stick to capacity here. So how can we decide if a patient truly understands the nature and consequences of a decision? There's no one clear answer here. No, you do this test and if they pass, they're good kind of answer. But an approach is to check a patient's understanding of the information presented. As we talk with patients, we want to present information clearly and with a minimum of medical jargon, as is appropriate for the patient's level of health literacy. But we also want to be sure that we are presenting a complete picture with risks and benefits clearly stated. Maintaining a patient's autonomy requires this of us. As you present information to patients, you can also ask them to teach you back, to review in their own words what's going on, what their options are, and why. It's a chance for patients to ask questions and for you to check their understanding. If it's done well, it should not feel like a quiz. I say here also to check their orientation. This doesn't mean that if they don't know that it's Friday and they're on the 7th floor of the hospital that they don't have capacity. But the question is, are they aware of their situation? Can they tell you why this decision is relevant? If you know the patient or can talk with people who do, you can also see if this current decision is consistent with their prior decisions. Is someone who is refusing treatment a person who had always said they wouldn't want to be kept alive with machines? Then that makes sense. It supports the decision. That's not to say that people can't change their minds. To decide to be intubated when faced with the alternative is not that uncommon, but it helps if you can know a patient's prior wishes or how they lived their lives. For a patient to have capacity, they also need to be able to communicate their wishes. Someone who is unable to do this for whatever reason, loss of consciousness, sedation, stroke, cannot have capacity at the time. It is possible to recover capacity, for example, when sedating medication wears off, so being aware of anything that can temporarily alter your patient's mental status is important. For example, if you're sent to consent a patient for surgery, it is best to do it prior to when they receive enough morphine that it's difficult to wake them up, but it's probably also best not to do it when they're in so much pain that it's difficult for them to concentrate on your words. This ends up being a judgment call, and we all do our best with it. If in doubt, psychiatry can be helpful with these decisions. They're trained in talking with patients and can be useful in evaluating whether a patient retains capacity due to psychiatric illness, but also other conditions that might impair capacity. Capacity is important in a number of areas in medicine and research, but today we'll talk about its application at the end of life. You may have seen some of these statistics here before, but I think they're relevant to our discussion here. We're all going to die one day, and most days we don't spend much time thinking about it. But when asked, most people will say that the type of death they would choose to have is a peaceful, quiet one at home, surrounded by loved ones. Over 80% of patients with a chronic illness say they want to avoid hospitalization and ICU care at the end of life. And yet the reality is that almost 70% of people in the U.S. will die in hospitals, nursing homes, or other long-term care facilities. There's some evidence that this is not as true for physicians. While there's no solid data on actual site of death of physicians versus the general population, anecdotally, physicians seem to have some different choices about prolonging treatment at the end of life and in making these preferences known. 20 to 30% of the U.S. population has advance directives, while one study showed that 64% of physicians do. Why is this so? In part, maybe because we're more fully informed, are able to navigate the system. We may understand a bit better the futility of care and the pain that may come with continuing it. Because of this, we have an obligation to provide some of this ability to choose, as best as is possible, how one wants to die, to our patients as well. Well thought out advance directives are one small way in which we can try to accomplish this. It's obviously less likely that a patient's wishes will be followed if no one understands what they are, and maybe much more likely that patients and families will be guided by fear or avoidance of later guilt rather than their values if they're not prepared. So what are these advance directives? There are several types which we'll go through, but the unifying theme is that they are intended to help continue respect for autonomy by guiding care when a patient cannot speak for themselves. The forms themselves and what they are called can vary by state. We'll focus on Massachusetts here because that's where we are. Here we have the healthcare proxy and living will. We'll also talk about what a surrogate decision maker is. First, healthcare proxy. A healthcare proxy is a document wherein a patient can appoint a person to make healthcare decisions for them in the event the patient loses capacity. In Massachusetts, there's a standard form, and it is a legal document. You can get it online, though, and fill it out yourself. It does require 2 witnesses, and it's a good idea to discuss your wishes with the person you're assigning as proxy. The link here will take you to it so you can see what it looks like. Another option is living will. This is a written document directing care in the event of loss of capacity. In this document, a patient can state what life-sustaining treatment they would like to receive or not. It's okay to have both of these documents. The living will can help guide the decisions a healthcare proxy might be expected to make. In Massachusetts, though, which is not common elsewhere, the healthcare proxy can override a living will directive because there is no legal statute authorizing living wills here. There are other terms that you may hear related to advance directives. Some of that is because, as I have said, the terms vary some by state. Here we consider durable power of attorney to involve a person designated for handling financial affairs if a patient lacks capacity. Many other states also have a medical power of attorney, also called durable power of attorney for healthcare, which is really very similar to what the healthcare proxy is here. In Massachusetts, we also have the MOLST form, which you may have heard of. It stands for Medical Orders for Life-Sustaining Treatment. You can take a look at it at the link here. It's a form to be filled out in discussion with a medical provider and signed by both provider and patient, outlining the care a patient would like to receive, including whether they would wish to have CPR done, intubation, dialysis, artificial nutrition, or hydration. Patients can keep a copy of this form with them to help with direction of care, especially in an emergency. It's typically used with terminally ill patients. In its original form, it's bright pink, and patients are told to keep it with them and at home in a visible place, like on the refrigerator. EMTs are trained to look for this form and follow its directives as they would other medical orders. Finally, if none of these resources are available, we would look to the next of kin to be surrogate decision makers for the patient. We would hope that they have some knowledge of what the patient would have wanted and will base their decisions on that. There's a set order of priority for who is the surrogate, with the patient's spouse being first, followed by adult children, parents, and then adult siblings. If there was a conflict between these groups, this is the hierarchy that we would follow. To understand choices and decisions at the end of life that one might be asked to make, and to know what choices one is allowed to make, we need to define a few terms. Euthanasia is the act of ending a life to relieve suffering. It could be voluntary, the patient is requesting death, or involuntary, against the patient's wishes, which would clearly be murder. Either type of active euthanasia, in fact, is not legal anywhere in the United States. Physician-assisted suicide has been much in the news in recent years. This is where a physician provides means for a patient to end their own life. This is legal in a few places in the U.S. Oregon, Washington, and Vermont have a process by which patients who meet certain requirements can obtain lethal doses of medication from their physicians. In Montana and New Mexico, the courts have said there's no prohibition against physician-assisted suicide, but there's not such an approved process. These differ greatly from refusal of treatment and withdrawal of life support. A patient with capacity can always refuse treatment, even if that leads to their death. If the life-sustaining treatment is started, a patient can later refuse or request withdrawal of life support, as can their designated proxy if the patient lacks capacity. A final term you may hear is double effect. This is the concept of giving pain medication with the intent of easing suffering, while knowing that a sufficient dose to relieve pain may also hasten death through respiratory depression. This is generally accepted as an ethical practice, with the key issue being what is the intent of the physician. As you can imagine, there are many ethical concerns with care at the end of life. We will talk in class a bit more as we work through a case about balancing the principles of beneficence and non-maleficence as we approach these dilemmas. Just a few points to keep in mind as you work through the case. We need to be alert as to the motivations of patients, families, and ourselves. We don't want anyone to make a decision, especially a life-ending one, because of coercion by others, nor because the patient feels that they are a burden to their caregivers or society because of financial constraints or other investments in their care of time, space, or emotion. We also want to consider whether a desire to die is motivated primarily by depression or hopelessness or the inadequate treatment of pain. Is it possible that if these issues are better managed, through hospice care for example, that a patient would still want to die? It's a question worth asking. Finally, it can be very difficult to predict when a patient is going to die. We're not very good at it. One study estimating survival of hospice patients showed that physicians were accurate 20% of the time, and we tend to overestimate the amount of time a patient has left. So in discussing prognosis with patients and families and how their care can be managed, this is also a limitation. So much of this may not seem like the most relevant to your life right now, but it has been shown that about 20% of physicians will receive a request from a patient for help in ending their life at some point during their career. So it's worth thinking through this. The numbers are much higher depending on which field you choose to go into. Oncology, for example, was closer to 50%. In Massachusetts also, while physician-assisted suicide is not legal now, it's possible it may be at some point. We had a ballot question on physician-assisted suicide in 2012 that was very narrowly defeated, and so is expected to be put up again to a vote at the next possible time, which is 2018. So as I said before, in class we'll talk about some of these issues and tie them back to the principles we talked about last class, particularly autonomy, beneficence, and non-maleficence. Any questions before then, please let me know. See you in class.